What is the clinical presentation of the simple virilizing form of 21-hydroxylase deficiency?
The simple virilizing form produces sufficient mineralocorticoids to prevent a salt wasting crisis. However, the diminished glucocorticoids lead to excess ACTH and subsequently elevated androgens, which cause masculinization and ambiguous genitalia in females or precocious puberty in males.
What is the second messenger of the ACTH receptor?
Cyclic AMP is the second messenger for the ACTH receptor, which is a G protein coupled receptor in complex with a simulatory G protein, GS.
In addition to testosterone, DHEA and androstenedione serve as precursors to what?
DHEA and androstenedione have weak androgenic activity and serve as precursor to the estrogens.
Here's a good question. In a patient with a single benign adrenal tumor, laboratory measurements show a high aldosterone and a low plasma renin. In addition to a surgical referral, you recommend treating this individual with A, furosemide, B, hydrochlorothiazide, C, calcium, D, spironolactone, or E, magnesium. Correct answer is D, spironolactone.
In primary hyperaldosteronism, increased sodium and water retention is treated with spironolactone. Spironolactone is an aldosterone antagonist diuretic that has the additional benefit of being potassium sparing. Primary hyperaldosteronism is associated with hypocalcemia. However, treatment with calcium is rarely necessary in this situation.
Question. Aldosterone acts on what two locations in the nephron?
Mineralocorticoids, like aldosterone, exert three effects on the renal tubules by acting at the late distal tubule and the collecting duct.
Why do patients with primary or secondary hypoaldosteronism have hypertension?
Hypertension results from increased sodium and therefore water retention.
What enzyme is stimulated by ACTH at the adrenal cortex, and what reaction does this enzyme catalyze?
ACTH increases steroid hormone synthesis in all zones of the adrenal cortex by stimulating cholesterol desmolase, the enzyme which converts cholesterol to pregnenolone.
Okay, another good question. An HIV positive individual is found to have hyponatremia, hypoglycemia, and hypokalemia. Hyperkalemia in a routine lab analysis. What is the likely explanation for these lab values? The correct, possible answers are HIV-related destruction of adrenal cortex, that's A. B. Glomerulosclerosis, nephritic disease due to HIV progression. C. Hypopituitary function resulting from HIV-related infarcts. And D. A lab error in analysis.
HIV is a known etiology for primary Addison's disease.
So the correct answer is A.
nephritic disease may also result from HIV. However, it would not explain hyponatremia or hypoglycemia. Hypopituitary function may cause secondary hypoaldosteronism with the lab profile described in the question. However, HIV does not cause ischemic infarct.
What laboratory test is used to screen for Cushing syndrome?
The hallmark of Cushing syndrome is increased cortisol, as demonstrated by an increased 24-hour urinary free cortisol excretion level.
What abnormal lab test is definitive and diagnostic of primary adrenocortical insufficiency?
Cosintropine, which is synthetic ACTH, should result in a brisk increase in cortisol levels. An abnormal cosintropine stimulation test implies a subnormal response of plasma cortisol following cosintropine administration, and it is definitive and diagnostic of primary adrenocortical insufficiency.